Continue our program, and our next speaker is Dan Burkhoff, who you just heard from earlier. I've known Dan for probably the longest in this audience here, except for maybe Kenji. Just to say that Dan comes from a cadre of cardiovascular scientists trained by the late Dr. Kichi Sagawa, who's one of the pioneers in hemodynamics, cardiovascular hemodynamics, and Dan has continued that legacy through multiple endeavors, including his very popular Harvey program on the iPad, which he started actually when he was a graduate student many years ago, but now has become really just a functional tool for hemodynamics. If anyone hasn't seen it, you should look it up, HARVI. Dan continues work on hemodynamics. He's been the medical director in heart failure research for CRF, has been the medical director of multiple startup companies for devices, and it's a real pleasure to have him talk today. Dan.
Thank you very much. And it's, of course, difficult to follow Dr. Braunwald. And I also think that most of the talks that we'll see today are, in one way or another, derivative or extensions of what Dr. Braunwald started over the last 50 years. And for sure, the talk that I'm going to give definitely will build on many of the issues that he touched on. So when we talk about unloading, myocardial unloading, there are clinical goals and there are ways that we achieve those clinical goals. So what is our clinical goals in acute myocardial insult? And I've used the term insult rather than infarction to kind of expand the topic a little bit, because a lot of the issues that are present that we encounter in patients with cardiogenic shock are not restricted to myocardial infarction. Many patients with chronic heart disease present with cardiogenic shock, and the issues are not totally, there are many overlapping issues with patients with and without ischemic heart disease. So first of all, we're interested in myocardial salvage. We want to minimize the amount of myocardial loss. We want to prevent or at least limit myocardial and ventricular remodeling. I think this is really a key thing, and Dr. Braunwald touched on this a little bit, but really the work from Janice and Mark Pfeffer and Dr. Braunwald in rat MIs, where they defined what remodeling was, have profoundly influenced our thinking about this process. So we really want to prevent that dilation, and we want to maintain normal LV size and through that normal function. Of course, we want to improve survival. We've seen multiple slides showing that survival is dismal in patients presenting with a cardiogenic shock, both in the first 30 days, but also persisting over the next several years. So what are the physiological goals that we use to achieve these? Well, first of all, we've talked about the numbers. We want to normalize cardiac output, mean arterial pressure, CVP, wedge, and an index. If we look at mixed venous saturation, that's also certainly, these are the numbers that we talked about. I think we want to reduce LV preload as a separate issue to prevent the acute stretch that really leads to the remodeling. And we've already touched on many times, we want to minimize oxygen consumption, and we'll talk about, Dr. Braunwald already summarized the major contributions to oxygen consumption being heart rate, LV contractility, and then myocardial work. Now, there are many things that have brought many prior experiments and people involved with limiting the use of mechanical circulatory support to minimize myocardial infarction. And this is one group. Bart Maines really has been studying the use of mechanical support since the mid-90s, when he first got access to the early versions of the Impella device. And this is one of his more recent experiments from, it's already more than 12 years old, 13 years old, but here you can see that we've got the area at risk is shown in the open bars, and then the percent of the area at risk that is infarcted. Here you see the control, which has 60 minutes of ischemia and 120 minutes of reperfusion. You see that you have 70% of the myocardium at risk is infarcted. If you unload the heart during ischemia and reperfusion, you have very little. You've really reduced the amount of infarction by a factor of 4. And if you apply unloading only during reperfusion, or if you apply only partial unloading during reperfusion, you see that you here have a progressive increase in the amount of infarction. And what they also measured was the oxygen consumption, and this really is a very important recurring theme, is that the amount of the infarcted area is related to the oxygen consumption during ischemia and also during the reperfusion. So the efforts to minimize oxygen consumption are really critical, I think, in this thing. And this, again, we will see this time and time again. So what are the determinants of myocardial oxygen consumption? Dr. Brownwald talked about this. More recently than the work that was done looking at stress as the index of work, the work from Hirosuga when working with Dr. Sagawa really showed that the index of work that correlates most closely with myocardial oxygen consumption is called the pressure volume area. The pressure volume area is the area on the pressure volume diagram that is the sum of the stroke work, which is the area inside of the loop, and this extra triangle to the left, which is bounded by the end-systolic and end-diastolic pressure volume relations, and the diastolic portion of the pressure volume loop that's called the potential energy. This is energy that is stored in the myofilaments at the end of contraction that is not released as external work, and it's really the sum of these two, potential energy plus stroke work, which is defined as the pressure volume area. And you see at the bottom here that there is a linear, a linear relationship between pressure volume area and oxygen consumption. It doesn't matter how you arrive at a given pressure volume area. These are different preloads and different afterload conditions. So you could have a contraction that is isovolumic and have a very large pressure volume area with almost no external work that would really give you the highest pressure volume area and the highest amount of energy consumption. So these are this is the mechanical index that we look at in terms of the closest correlate to oxygen consumption. Of course, heart rate and contractility we've talked about, but we can look a little bit more into this relationship. So here we have, and the important thing, one of the important things is that you could see when there's no external work, no pressure volume area, there's still quite a lot of oxygen consumption. And this is because, again, as Dr. Brownwald already discussed, there's basal metabolism and energy utilization by all cells that we have to account for. Then there's another part here that accounts for the unloaded oxygen consumption, which really mainly relates to calcium cycling. And this is the link with contractility. This is why contractility changes is so important in this equation of oxygen consumption. And then the oxygen consumption above this intercept, that's the unloaded oxygen consumption, is due to the actin-myosin uncoupling. That's the mechanical work or the pressure volume area component of the oxygen consumption. So this is kind of how the energy utilization is kind of partitioned when you look at it from this mechanical standpoint. Now, so when you increase contractility, and this is again why drugs, inotropes, are so detrimental, it increases the amount of calcium. The inotropes work by increasing calcium cycling, and that increases the intercept that is the unloaded oxygen consumption. So this is the mechanism whereby these drugs work. And now heart rate is extremely important because the heart uses energy on a per beat basis as opposed to a per time basis. With each contraction, you have the release of calcium, and you have to pay for that with oxygen to sequester the calcium, and you also have the actin-myosin interactions. So this is now oxygen consumption in mLs O2 per minute. If you increase heart rate, you're going to increase both the intercept and the slope of this relationship. And so we really, although heart rate is a very trivial thing, and we can't forget how important this is in the equation. So I've already shown this definition. I think that these theoretical considerations lead us to a clinically useful definition of LV unloading, which is the reduction of the total mechanical power expenditure. So power instead of work, so work is the amount per beat, but power is the amount of work that's done also in consideration of the heart rate. So it's the power expenditure of the ventricle, which correlates with the reduction in myocardial oxygen consumption and the hemodynamic forces that lead to ventricular remodeling. And again, we can talk about this. So what are the ways of achieving the physiological goals? Well, we've already mentioned pharmacologic inotropic agents and pressors, and then we have devices. And we've heard about balloon pump. We heard about left atrial to aortic pumping, which is the tandem heart. We heard about LV to aorta pumping, which is the Impella device. But the other device that's now used very commonly in cardiogenic shock is ECMO, right atrial to aortic pumping. And really the important thing is that these devices are not created equally. These devices, because of the fact that they take blood from a different port of the system, although they all deliver blood to the same part, the arterial system, because they take the blood from they source the blood from a different chamber, they have very different effects, especially on the ventricle. I won't talk more about the balloon pumping because Dr. Brownwald already has shown that we really don't have, that the data currently do not support the use of balloon pumping in cardiogenic shock. I won't talk also much about tandem heart. It is in the expert opinion that you saw. Its use has been a little bit limited by the fact that it requires the transeptal puncture and therefore is a little bit more difficult to implement in the acute setting. And its use in comparison to other devices has not really increased very much. It's actually decreasing over time. So let's look at just, these are pressure volume loops and the oxygen consumption that you would see with inotropes. So here, what you have with inotropes, you have both an increase in the heart rate and also increase in the contractility and the pressure volume area. So as the contractility has increased there, you see the dot, the black dot, which is the myocardial oxygen consumption PVA, increasing. And now, first I increased the contractility, and now we're using a pressor to increase the total peripheral resistance. So you see the increase in the intercept due to the inotrope, and then you have the further increase in contractility for the oxygen consumption due to the pressure volume area increase, which you get with the inotrope, and then following that is the further increase due to pressors. So these are kind of what you would see with your patient if you gave an inotrope and a vasoconstrictor. So I think that this really clarifies, if your goal is to reduce oxygen consumption, this is really not the way to go. And I think in the end, our goal should actually be to completely avoid these drugs, and the use of mechanical circulatory support, I think, has a means of replacing these things. So this is now just a demonstration of what happens with heart rate. I've already shown this kind of in a static way, but as the heart rate is increasing, you see again the increase in the intercept, increase in the slope of this line. Not much huge effect on the pressure volume loop itself, but now of course the cardiac output is getting better because we have more beats per minute. Again, the numbers are improving, but this is really providing a very detrimental effect on the oxygen consumption. So I think that, again, heart rate is a very simple thing to think about, but its role, I think, in increasing oxygen consumption may be a little bit underappreciated. So we've already seen, I've talked a little bit about all these different devices. These are, as you see here, this is the balloon pump. This is the Impella device. This is the ECMO, and this is the tandem heart. In red is a baseline pressure volume loop in cardiogenic shock. And then what you can see is each of these devices has a characteristic effect on the pressure volume loop, which is different depending on which device you're using. And I'm just going to now go through pressure volume loops from two of these devices. This is now the right atrial to aortic mechanical circulatory support called ECMO. With ECMO here, we are taking blood from the venous system, basically either from the inferior vena cava, superior vena cava, or right atrium, pumping it externally, going through an oxygenator and returning it to the arterial system. And what you could see is that here, because the ventricle has to eject blood, through the aorta, the only means of getting blood out of the ventricle is through the aorta, the ventricular end diastolic pressure will rise during the use of ECMO so that it can accommodate and reach the higher pressures that are now that it's facing due to the increase in the arterial pressure. It results in an increase in the load, increase in the preload on the ventricle, and as a consequence, you could see here on the energy diagram that the pressure volume area is increasing and also the oxygen consumption is increasing. So here we see three important things. One is oxygen consumption of the heart itself can be increasing. The preload can be increasing, which can result in pulmonary edema, and also we're increasing the pressure in diastole that can also promote remodeling with the detrimental effects of remodeling. So these are without any, if there's no other strategy that's employed in combination with ECMO to unload the ventricle, you have here an energetically unfavorable condition and also a condition that's unfavorable in the sense of myocardial remodeling. Now this is a ventricle to aorta, a true ventricular assist device like the Impella, and you see here that we have the opposite effect, that when you draw blood directly from the ventricle, that the loops shift leftwards towards lower volumes, and you see that the pressure volume area is decreasing, and you also have a reduction in the end diastolic pressure. So this is favorable from both the point of view of myocardial energetics and from the view, from the perspective of myocardial remodeling in the acute setting. And there's one other very important point as it relates to when you pump blood from ventricle to aorta, which is the concept of LV aortic uncoupling. So here you see at the bottom is the ventricular pressure tracing and the aortic pressure tracing. If you provide sufficient unloading, your loops shift leftwards, your pressure generation inside the ventricle reduce, but at the same time, you're able to increase and maintain higher levels of pressure in the arterial system. And this really accomplishes what improves the numbers, that is, improve the blood pressure, improve the forward cardiac output. But unlike the drugs, which can improve numbers, you're doing that with a reduction in the myocardial energy consumption, a reduction in the pressure volume area, a reduction in the forces and in diastole that will drive the remodeling process. So a big distinction, and this is why I think that what this type of a device can do is really completely replace inotropes, and will allow us to avoid those toxic effects while still achieving both the clinical and the physiological goals. Now, one final point I wanted to make is about, and a little bit about terminology, is that unloading is there's a dose dependence. And there's also a distinction between partial support and partial unloading and full support and full unloading. So there's a little bit of terminology. Here we have, in this pressure volume loop here, we have partial support and partial unloading. So partial support, what I use that term, is when the heart is providing some of the cardiac output and the device is providing some of the cardiac output so that the aortic valve is still opening. And we know that the aortic valve is still opening here. You can see on the ventricular pressure and aortic pressure tracings that there's a little blip here that represents aortic valve opening and ejection of the ventricle. So this is a case where we have partial support. So we use this term in the mechanical circulatory support world quite a lot, but just to put a little definition behind it. So we've partially unloaded the ventricle and we're partially supporting the circulation. The next degree of support here is full support, but still partial unloading. So full support means that the entire cardiac output is being provided by the mechanical circulatory support device. And we know that in this case because you see here there's this uncoupling between ventricular pressure and arterial pressure. So the ventricle here is not ejecting at all, and all of the cardiac output is coming from the device. So we have full support, but we still have partial unloading, and we've reduced the oxygen consumption a little bit. The next degree is full support and a greater degree, but still partial unloading, meaning that the device is providing all of the blood pressure, all the cardiac output, and we've created more unloading, and we've reduced myocardial oxygen consumption to a greater degree, but we're still not fully unloaded. Full unloading is really when you completely suck down the ventricle, and the ventricle is having really no minimizing the oxygen consumption due to external work. So here we have a case of full support and full unloading. So unloading and support are not necessarily equivalent. So I think it's an important distinction as we start getting into some of the details discussions when we talk about unloading and the degree of support, because sometimes people think that when you have full support, you have full unloading, and that's really not the case. So in summary, with acute hemodynamic compromise and setting of myocardial insult, we want to restore normal hemodynamics. We want to improve the numbers, but we want to minimize the filling pressures to prevent remodeling, and we want to minimize oxygen consumption to enhance myocardial recovery. Pharmacologic approaches increase oxygen consumption and increase the load on the left ventricle, and this is really not what we want to be doing. Different mechanical circulatory support options have different effects on hemodynamics and energetics. Right atrial to aortic pumping, ECMO, does not unload the ventricle by itself or reduce the myocardial oxygen consumption. And currently, I think you all know that this is probably the most popular approach now to treating patients with cardiogenic shock. So I think that the appreciation that a different approach, LV to aortic pumping, which unloads the ventricle and reduces the oxygen consumption, uncouples LV pressure generation from aortic pressure generation and allows for unloading of the ventricle while restoring blood pressure and flow, has a much greater potential of achieving the goals that we want to on the clinical side. Thanks.